It's just for a whistle-stop tour of IDD therapy and what that is. So what is IDD therapy? Well, it's basically a computer-controlled mechanical spinal decompression. There's a non-surgical treatment, people with disc pathology, radiculopathy, degenerative changes and facet pathology as well. The aims of the treatment is to mechanically influence the disc, essentially increasing the volume of the disc by reducing the intradiscal pressure to a negative value to allow disc reabsorption. So in other words, mechanical reduction. To improve hydration, nutrition and oxygen simulation in the disc, I think that was touched on this morning with healthy discs, and to relax the reflex muscle spasm that you usually get around the disc that increases compression on that disc. Essentially, we're looking at kind of just creating a more optimal environment for disc to heal. So patients are simply strapped into a unit, and a targeted and precise decompression force can be applied to the damaged disc via a computer-controlled system. Not quite like the Medtronic guys, but it's pretty technical nevertheless. So where did it come from? I mean, really, it's an American system. It really came off the back of a study in 1995 that showed that axial decompression could reduce discal pressure significantly. This was kind of taken up by an American neurosurgeon who was concerned with kind of cases of surgery that probably weren't cases of surgery. And he was looking for alternatives to that. And this study kind of got him thinking about the therapeutic possibility of using mechanical disc reduction rather than surgical. And in 1997, he published a trial using this new computer technology where he kind of compared it with traditional traction and found that this showed to be much more effective. And he went on to develop this technology with protocols which kind of IDD clinicians still use today, although slightly tweaked. In the UK, it's a relatively kind of new kid on the block. It started in Scotland, in Glasgow, actually, 2008. We started in 2010. We were the third clinic in the UK to have it. But it's grown consistently over the last 10 years. And at present, there's only 50 clinics that are providing this treatment in it. Now, when I always do this presentation, I always get asked, yeah, but it's just traction, isn't it? And the answer is, it's based on the principle of traction, but it's very different because the computer technology allows accuracy and precise control of the distraction forces that you wouldn't really be able to dream of with a traditional traction treatment. Because it's computer controlled, you can use a sinusoidal waveform pattern. So it means that we hold a high tension for only 60 seconds before reducing it, which means that we can get physiological changes within the disc at a lower tension, which is better tolerated by the body than traditional traction, which just uses linear pulling. And probably the unique thing about this therapy is it applies a slow oscillatory stretch, which stimulate the Golgi tendon organs. Now, these create autogenic inhibition of the spinal extensor muscles. So basically, we can initiate a reflex relaxation in the muscle, which is important for relieving pain, but also decreases the compressive force acting on the disc. Traditional traction can't affect this inverse stretch reflex, and unfortunately it can stimulate muscle spindle activity, so it can actually increase muscle contraction and therefore increase discal pressure. So a little bit like comparing a kind of shopping trolley with a Porsche, really. The next one. Is there any evidence supporting IDD? The answer is yes. There is. I mean, in 2021, there was some evidence statistically significant improvement in low back pain could be achieved by this. 2017, again, statistically significant improvements in cervical lumbar pain. And way back in 2006, 92% of 129 lumbar surgeons successfully avoided surgery. Again, like all evidence, more evidence is needed. And that's what a lot of research showed, that more research is going. But most of these are small-scale studies, but they do show that it is an effective sort of treatment. There is a clinical literature compendium, which I've put a little QR code there. So if anyone wants to see me afterwards or scan that, if you're interested at all, please feel free to do so. So what does it look like? Who do we see? So many cases, patients undergoing this treatment as an alternative to surgery. So either they're not They're unable to have surgery, or they're not very keen on having surgery or even epidural injections. Manual therapy is highly effective for disc. I think we've seen in the sessions this morning that I think 2 disc problems settled pretty well with manual therapy. So we will not tend to use this under 3 months, and if the patient hasn't had manual therapy first. It's only if the manual therapy has failed that we'd consider putting them on this treatment. It requires an intensive program spread out over a 4 to 6 period. And as I think everyone else has said, rehabilitation is essential to prevent further recurrence. So let's have a look at a couple of case studies. So we've got Tom, 4-month worsening sciatica. He'd initially had chiropractic treatment, which helped but then stopped working. But his symptoms were still getting worse with increasing nerve pain. Pretty fit guy up to then, and meds only really gave him 4 hours relief. This was his chart on when he came in. So we see quite a lot of action going on there in his right leg. The signs and symptoms, he had real problems sitting, 8 out of 10 pain. His Kiel start-back score was kind of moderate. His disability score was 62%. His functions wasn't great. Everything really caused him pain. Mobility neurotesting, extension rotation, reproduces leg pain. He'd reduced S1 reflex on the right, and he had a positive neurodynamic stretch test. This was his MRI. So he had significant central, I'm not allowed to say that anymore, am I? Sorry. L5S1 disc bulge there, and on transverse, we can see there where it was affecting the right S1 nerve root. So Tom had the 6 weeks of treatment. This was his pain chart when he finished the treatment. His signs: hadn't had any meds from week 2. His VAS had reduced. In fact, he only had pain when he was sat, and that was only 2. Oswestry reduced from 62% to 24%, and pretty much, apart from sitting for 30 minutes, all of the rest of his function had been restored. His mobility neurotesting, he had pain-free mobility in all ranges. S1 reflex had returned, and he had a normal neurodynamic test. So Tom was pretty happy with that. Another case study here. This was Julia. 4 weeks of really nasty right sciatica and quite rapid functional loss. She'd been seen by a triage physio, and she'd been sent to a neurosurgeon and told that only surgery could help her. She was absolutely terrified of surgery. She really didn't want to go there and was looking at exploring every opportunity. But the symptoms were getting significantly worse. She was getting progressive paresthesia and anaesthesia in the kind of L5 dermatome and some weakness in the toes. She hadn't had any leg pain before, but as like a lot of these disc patients, they have a kind of previous history of grumbling low back pain, which then was suddenly changed to become leg pain and cause problems. She's on tramadol and diclofenac. Her signs: pain was reasonably high, not that great, but she was on opiates. Her function was pretty poor. She couldn't really do anything. Her disability was at 64%. Her signs: all movements really caused her problems. She had a 10 to 20% reduction in sensation over the right L5 dermatome. Big toe dorsiflexion had been reduced. She also had a positive nerve root test on the right. This was her MRI when she came in. Again, quite significant L4-5 there. And again, from the transverse, we can see that kind of right L5 nerve root impingement. So as I said, we said, look, let's try this on as a hope of preventing you having surgery. And after 6 weeks, her signs, so she had occasionally tingling calf pain. She's off all meds. Her pain had dropped significantly. All of her function had pretty much returned to normal. In fact, she'd gone back to swimming. Her mobility, pretty much full pain-free. Sensory loss had pretty much gone, still a little bit left on that L5. But the big toe power had returned, and the straight leg raise test was still a little bit low with some lower extremity pain. But she continued with a rehab program, and over the next 3 months she continued to improve massively. And 6 months post IDD, she was pretty much back to normal. She had follow-up MRI scans, which that was the same level. So we can see that complete reabsorption of the disc there, and that was the transverse spine as well. She had IDD back in 2012 and still in contact with Julia. In fact, She's just got back from a cycle tour of southern France and has no problems at all now. So her disc bulge hasn't recurred. So she's not the only one that does well with this. These are a summary of our clinical outcomes, and we can see we have 90% of lumbar disc prolapse with radicular symptoms treatment had an average improvement of 74%. And from our satisfaction data, most of our patients are pretty happy with this. Hopefully, that's whizzed through that fairly quickly. Sorry, it's a bit of a whistle-stop tour, but I'm very conscious of the time. But if anybody wants to know anything more or interested more or would like to refer anyone, please have a chat with me afterwards. So thank you very much.